Hi, everyone. Thank you so much to the organizers for inviting me to speak at this viral hepatitis plenary, and thanks to everyone who's joining and listening to the talk as well. The title of my talk is Hepatitis C Treatment in Thailand, Spotlight on the CFREE Study, Community-Based Testing and Treatment for People Who Use Drugs. I'm the Director of Research and Advocacy at Dreamlopments, and you can see my email address here in case you have any questions. So an outline of my presentation. The first part of my presentation, I'm going to talk about hepatitis C epidemiology in Thailand and barriers to treatment under the current programs. In the second part of my presentation, I will talk about CFREE study and the community-based care model that we're implementing, as well as a study update and some results to date. Finally, acknowledgments. So first, hepatitis C epidemiology in Thailand. Between 760,000 and 1.5 million people are estimated to be antibody positive in Thailand, which means they've been exposed to hepatitis C in the past. An overall prevalence is around 1% for the entire population. However, there are key populations who are disproportionately affected. These include people who inject drugs, and seroprevalence surveys of people who inject drugs throughout Thailand through the 2000s showed HCV antibody prevalence between 60 to 90%. A more recent study among methadone center participants in Bangkok showed around 45%, but many of these people were no longer injecting drugs. Additionally, HIV co-infected patients often are infected with both HIV and hepatitis C, especially PWD, because of the shared route of transmission and very efficient means of transmission of hepatitis C and HIV as bloodborne viruses. Globally, PWD are estimated to make up 50 to 60% of all HIV Hep C co-infected people. There's also an HCV epidemic among HIV positive men who have sex with men in Bangkok, Thailand. And this data is from a cohort of patients who enroll when they are diagnosed with acute HIV infection, or the RV254 cohort at SEARCH in Bangkok. And this data has been published in JADES and is also being presented here at APACC 2020 as an oral abstract. And so you can see in this cohort, which is 98% men who have sex with men, there were no incident hepatitis C cases between 2009 and 2013. However, between 2014 and 2016, there was an uptick in cases, around 10 per 1,000 person years follow-up. Finally, in 2017 through present, there has been a drastic increase in acute or incident hepatitis C cases. And you can see in 2019, it was high as 49 per 1,000 person years of follow-up. We did an analysis to look at what risk factors were associated with hepatitis C incidence, and they included crystal methamphetamine use, group sex, and syphilis. So you can see those who use crystal methamphetamine were more than 3 times likely to have incident Hep C infection compared to those who did not. Notably, close to 80% of these incident Hep C cases denied injecting drugs. In Thailand, there are 3 main genotypes if you look at the HCV genotype distribution. So the most common traditionally has been genotype 3, followed by genotype 1, and then genotype 6 infection. This is unlike some countries in the West, such as the United States, where genotype 1 is prevalent. So, switching gears to HCV treatment in Thailand, access to hepatitis C treatment has been limited due to multiple factors. The first is just market availability and registration. Many DAAs have not been registered in Thailand, and so are just not available. The current DAAs available include sofosbuvir ledipasvir, or SOF-LED, and this is currently available in the national program, which is health insurance for all Thais. And right now, SOF-LED is recommended for genotypes 1, 4, and 6. For genotype 3, SOF-LED is not effective, and so sofosbuvir plus pegylated interferon and ribavirin is still recommended. This leads to many people with genotype 3 infection not pursuing treatment because they know DAAs are available and they don't want to have all the side effects and injections associated with pegylated interferon. Second, sofosbuvir velpatasvir. This is a pan-genotypic regimen, and the generic produced by Mylan were approved by the Thai FDA in August 2019. It's currently not available in the national program, so people have to buy this themselves and it's quite expensive, but it may enter the national program scheme at the end of 2020. Finally, another DAA, sofosbuvir declatosphere. This is registered, but it's not currently sold in Thailand, and the originator company has not allowed a generic company to use its license to produce declatosphere. Second, DAA reimbursement within the national healthcare scheme is restricted at multiple levels. So at the hospital level, you must be at a large provincial hospital that has access to both laboratory and imaging studies, including hepatitis C RNA, as well as FibroScan. This greatly limits the access to people who live in provinces or more rural areas who are not going to the hospital in larger cities. Second, at the physician level, only specialists are allowed to prescribe sofosbuvir velpatasvir or sofosbuvir ledipasvir. And these include gastroenterologists or internists who have at least 5 years experience, complete a special training course, and their hospital director has to sign off to say that they can prescribe this to be reimbursed under the national program. Finally, at the patient level, these are only a few of the criteria that you must meet to be eligible to access DAAs. Number one, your HCV RNA has to be greater than 5,000 IU per milliliter. Second, you must have F2 or higher fibrosis based on either FibroScan or liver biopsy. And this is very difficult to access, especially in smaller provinces. Finally, if you're HIV positive, you must have a CD4 of at least 200 and undetectable HIV RNA if you're taking ART. If you're not on ART, you must have CD4 greater than or equal to 500. Previous recommendations also disqualify people who were actively drinking alcohol or injecting drugs. For HCV treatment in HIV positive, we just talked about the CD4 criteria, but there's been extremely low rate of treatment and even testing in the National AIDS program to date. So Thailand has done an excellent job and does offer HIV or antiretroviral therapy to all patients living with HIV, regardless of their CD4. However, less than 20% were tested for hepatitis C antibody in 2018. And of those tested and positive, less than a quarter received confirmatory HCV RNA testing. So there was already a large drop-off in diagnosing those who with active hepatitis C who could possibly qualify for treatment. Currently, sofosbuvir ledipasvir or SOFLED is available in the national program. An advantage is it can be used with ephedrins, which is still first-line therapy in the National AIDS program. But as we discussed, it can't be used in genotype 3 patients, and that's still the most prevalent genotype in Thailand. When SOFVEL, or sofosbuvir velpatasvir, is included in the national program, this is great because it's pan-genotypic. You don't need to test genotype. However, it cannot be used concomitantly with ephedrins or nevirapine, and both are still commonly used in Thailand at this time. So this necessitates a switch in therapy to either an integrase inhibitor, protease inhibitor, or rilpivirine, and patients must take that for at least 2 weeks before starting treatment with SOFVEL. Because of all these factors, there's been extremely limited hepatitis C treatment nationally. So between April 2018 and February 2020, less than 1% of HCV infected people, so around 7,000 people, have received treatment under the Universal Health Coverage Scheme nationally. And around 4,000 have received sofosbuvir ledipasvir, and then around 2,500 have received sofosbuvir in combination with peginterferon and ribavirin. And so these are the genotype 3 patients who have received this combination. Now I'm going to switch gears and talk about the CFREE study and what we're trying to do to increase treatment access to people who use drugs and their partners. So the primary objectives of this were just to test a community-based model of care for hepatitis C, hepatitis B, and HIV among people who use drugs and their sexual and life partners. And then second, we wanted to assess the effectiveness in curing Hep C with DAA therapy in a community-based setting. So you can see all the criteria that we've discussed before. You need to have a hospital, you need to have a specialist prescribed, you need to get all these specialized tests. We wanted to say, no, you don't need all these things. You can do testing and treatment with DAAs in the community and safe and effective in this marginalized population. So our current study is a research protocol, and it's conducted at community drop-in centers run by partner NGOs, including Ozone Foundation and the Rex Thai Foundation. And we're expanding to work with the Thai Drug Users Network as well soon. So these drop-in centers are actually harm reduction centers where peers can come with community outreach workers or just drop in, and there are harm reduction services offered there, including needle exchange. So there are two parts of our protocol. One is a testing cohort where we offer HIV, hepatitis B, and hepatitis C testing every 3 months, and the target N is 3,000 participants over approximately a 2-year period. And then the second part is an Hep C treatment cohort. So if you test positive for hepatitis C, we offer you 12 weeks of sofosbuvir velpatasvir, and you meet all the eligibility criteria. And our target N is 1,380 participants. So for the cohort study, here are just the inclusion and exclusion criteria. First, you need to give informed consent, be any gender, at least 18 years old and above. And you either have to have previously used drugs, currently used drugs, or be the sexual or life partner of a drug user reached by harm reduction services or referred from other sources, and be willing to be tested and receive results for HIV, Hep B, and hepatitis C. For the hepatitis C study, it's similar. You need to have informed consent, give informed consent, be a participant of the CFREE cohort study, and then have active hepatitis C. We don't have a lower limit defined by any detectable HCV RNA on gene expert testing. For exclusion criteria to be treated, very few people have been excluded, but if you have previously been treated with sofosbuvir or any NS5A inhibitor and failed, we will not treat you, or you're not eligible. If you have decompensated liver cirrhosis, including Child-Pugh B or C liver disease, we must refer you to a hepatologist. And then there are some concomitant medications that you either need to get off of or switch to other medicines to be treated, including, as mentioned, ephedrins and ibuprofen. If you have active TB, we generally recommend being treated first because rifampicin or rifabutin and rifapentine cannot be used with Sofvel. And then if you have EGFR or kidney failure, less than 30 mils per minute, cannot use Sofvel, as well as evidence of active hepatocellular carcinoma. For women, if you're currently pregnant or breastfeeding or unwilling to use effective contraception method during the treatment period, it's also an exclusion criteria. So these are the procedures that we offer at the drop-in center with a research nurse that's on site every day. So they offer on-site antibody antigen testing with rapid tests for HIV, hepatitis C, and hepatitis B. And then if you test positive for any of these viruses, we have gene expert confirmatory viral load testing, so HIV RNA, HCV RNA, as well as HBV DNA. For HIV and HBV care, we offer HBV vaccination, 3 shots for non-immune patients. If you're diagnosed with HIV or hepatitis B, we help get you into care with the community outreach workers and support. And then we also just provide support and care for HIV and HBV through the viral load testing as well. For hepatitis C treatment, if you're eligible, we prescribe Sofvel to you, and then we also retest after SVR to assess for reinfection, especially if you're actively using drugs. Here are some pictures. So this is the gene expert machine, and this is a person getting hepatitis C viral load testing with a cartridge. This is a participant receiving hepatitis B vaccination. And then finally, this is a sofosbuvir velpatasvir tablet. You just take 1 tablet a day for 12 weeks. This is a study update for data from June 2019 when we started the study until June 2020. So we have 5 study sites currently in Bangkok and 2 southern provinces, Songkhla and Narathiwat. And these are the foundations and NGOs that we work with. So there's been a high rate of community interest in testing and treatment at the drop-in centers, and we've been successful in encouraging those who are HIV positive and or hepatitis B positive to re-engage in care or start therapy because they want to be treated for hepatitis C. We've provided Hep C DAA therapy to many patients. We've also linked active users to harm reduction services. An enrollment update as of September 24th, we've enrolled and tested 853 participants nationally. And for the hepatitis C study, we've identified 541 of those 853 participants have active hepatitis C, so 63%. There's a high rate of HIV Hep C co-infection. over half of those with active Hep C are also co-infected with HIV. And we've started DAAs in the majority of patients who are eligible in our studies, so 83%. The remaining are still waiting to switch antiretroviral regimens or have other factors such as needing ultrasound, et cetera, before they can start treatment. Next, I'm just going to talk about an interim analysis that we conducted with BioFix, which is our data management center, at the 1-year mark of our study. So the next slides will be based on data as of 30th June 2020. So after 1 year, we had enrolled and tested close to 650 participants, and we identified 417 persons, or 64%, with active hepatitis C infection. In our cohort, the majority are male, so 86.7% are male. The mean age is 43.2 years with a standard deviation of 9 and a range from 18 to 72. And close to 3/4 are actually referred by community outreach workers. So this is really a community-based study. In the hepatitis C study, of those we've been treating with DAAs, nearly half of them report actively injecting drugs at the time of treatment. Most report a lifetime history of injecting, so close to 70%. And then the remainder are either sexual or life partners of drug users or people who use drugs, non-injecting drugs. The median age of first injection among injectors was 19. And of current drug users, the most commonly used drugs include heroin, 41.2%, and then methamphetamine, which is close to 30%. Interestingly, nearly half of all participants currently take methadone, and actually many take methadone and use heroin concomitantly. Some background on HIV and hepatitis C in the study. So enrolled in the cohort study is 647 people across 5 sites as of June. 42.2% are HIV positive. Of those, 95% are taking ART, which is excellent and meets the second 90. Of the HIV positive participants, 86% are actually HIV hepatitis C co-infected, which is unsurprising given that most of the cohort has reported a lifetime history of injecting. And then the percent of those enrolled who have a positive hepatitis C antibody or have been exposed to Hep C is 78%. Of those who are hepatitis C antibody positive, 83% have also detectable HCV RNA. And then we use APRI score greater than 2 as a cutoff for those who may have cirrhosis. And so about 5% have APRI scores that are indicative of cirrhosis. And we refer these people to get an abdominal ultrasound prior to starting therapy to make sure they don't have hepatocellular carcinoma. For hepatitis B, around 5% of the cohort has hepatitis B co-infection, infection, and then hepatitis B co-infection, you can see below. There are 15 who are co-infected with Hep C, 7 who are co-infected with HCV and HIV, so triple infection, and then 2 have Hep B HIV co-infection. About a quarter at enrollment were Hep B immune, so they had anti-HBs positive. And then of the remainder who were negative for Hep B surface antigen and also not immune, close to 70% actually received vaccination, because as you can see by the age, most of these did not receive birth dose vaccination since they are in their mid-40s. We've had an excellent cure rate. And so you can see this is the CFREE HCV treatment cascade. The number who were diagnosed with HCV, eligible to receive treatment in our study, started treatment in our study, completed treatment, attended their SVR visit, and then achieved SVR. So our per protocol SVR rate for those who started treatment, attended their visits, including their SVR visit, is 94.1%. And the reason that there's a drop off here between started softball and completed treatment is because the study is ongoing at that time, so not everybody has completed treatment yet. But this is an excellent SVR rate, and it proves that drug users, whether they're active or former, can have the same treatment goals and cure rates as those who do not use drugs. We also collect SAES and incarceration data due to the nature of the population, as well as being a research study in the community. And so we've had 25 hospitalizations out of those 650 people, none related to study drug and many related to motorcycle accidents, which are quite common in Thailand, as well as other road traffic accidents. There have been 9 deaths in the cohort, and 4 of them had received sofosbuvir/velpatasvir. And you can see of those who had received sofosbuvir/velpatasvir, 1 had completed treatment and died of pneumonia immediately prior to their SVR time point. 1 had died of end-stage liver disease. 1 was a suicide, was lost to follow-up after the first bottle was given. And then there was 1 sudden death at home in an HIV co-infected patient at week 5 of medicine, which was reported as due to likely stroke. There's also incarceration of study participants. So there have been 13 incarcerations. Some of these people had been taking HCV treatment at the time of their incarceration, and we work with the Department of Corrections as well as Prison Health Services, so as nurses, to make sure that all those people who have been incarcerated can continue study treatment. And this is one excellent demonstration of why community outreach workers and working with community-based organizations makes a difference, because they can identify when their friends or study participants have been arrested, know where they are in prison, and can get the medication to them. Here are some pictures of people who were participants in our studies. Some of them are also community outreach workers, and they all gave their permission to share. As you can see, they were quite happy that they were cured from hepatitis C, as they were not being able to access treatment within the national schemes currently. So the take-home messages from my presentation are that the CFREE study is reaching marginalized populations, specifically people who inject drugs and people who use drugs. We're treating and curing them for Hep C and engaging them in HIV and HBV care. We really want to emphasize that SOFVEL and other DAAs are safe and effective for use in community-based settings. So here we have a nurse at the drop-in center every day, and a physician comes to study clinic once a week. We've documented no SAEs related to study medicine, and our SVR or cure rate is greater than 90%. So right now our per protocol is close to 95%, and about half of these people are actively injecting drugs. And so they're coming to their follow-ups, they're taking their medication, and they're being cured. Because of our study success, we have planned expansion to other provinces, either late this year or early next year, including Chiang Mai and Dak, as well as with Bangkok Methadone and community health centers through the Bangkok Metropolitan Administration. Finally, we really want to push for increased treatment access nationally and inclusion of SOFVEL in the national program. Finally, I would like to give these acknowledgments to our funders, specifically USAID, PEPFAR, linkages, and the Global Fund, as well as our partners that we currently work with. Thank you.